Hi everyone. My name is Maya Schonbach, and I'm a clinical psychologist, and I work here at Stop OCD. And today we're going to be going through common Q&A all about OCD. If you have any questions that pop into your mind, or if you came prepared, I really recommend that you write into our Q&A, into our chat. And I'll keep checking it periodically. I do have some questions prepared from clients already and from our therapists that suggested some frequent questions that they get asked a lot. But I really encourage you guys to write in anything that comes to mind, even if it's personal or if it's more general, because this is for you guys. All right, so let's get started. One of the first questions that I wanted to go through was is can OCD go away completely? And does recovery mean that I'll never have intrusive thoughts again? So this is often a really one of the first questions people want answered because if you're suffering from OCD, you want to know, can I get rid of this forever? Can I make sure that it kind of never comes back? So first of all, in my answer, I want to talk about something that's really central to OCD, and that is certainty. So the idea of one of the core concepts at OCD is that OCD loves absolute certainty. So if I were to say something like, yes, of course, like we can guarantee that OCD will never return. Um, we want to be really careful because that might kind of accidentally feed um, the certainty seeking process that OCD really is built on. So just in this answer, I want to kind of model this kind of idea of the balance that we look for is really in the idea of treating OCD. First of all, many people improve significantly. Many people reach a place where OCD doesn't control their day. The OCD doesn't control their relationships or their choices, and it's not a complete, huge part of their identity. Some people experience remission. But recovery doesn't mean that you're never going to have another intrusive thought ever again, right? Intrusive thoughts, they're part of being human. And really, the difference is that in recovery, the thought might still arise, but you don't have to engage with it for hours and hours and hours and rearrange kind of your whole life around it. Um, so really, if we're talking about the goal in recovery, we don't want to talk about I never want to feel uncertainty ever again. The goal kind of is more about, okay, when uncertainty shows up, when I feel distress from an intrusive thought, saying to yourself, I know how to respond. I can notice the thought. I can allow the discomfort rise and pass. I can resist doing the compulsion, and then I can return to what actually matters to me. So that is what I would look for. So I'm just going to check the Q&A and see the chat. And for anybody that's joined right now, we're doing the Q&A today. So if anybody has any questions about OCD at all, about treatment, about the disorder, about something personal, I suggest you to write into our the chat right now or throughout, and we'll go through that together. But I'll continue with some of the prepared questions that have been sent on me. Another question that was recommended was, what if I start doubting whether I actually have OCD or whether treatment will help me? So, it's really common actually, this kind of doubt in the sphere. Remember, we talked about just now about the idea of certainty and doubt being a core concept in OCD. And so, a common doubt that arises is, what if this isn't actually OCD? What if I'm different? What if the treatment, what if ERP, exposure and response prevention, works for other people, but it doesn't work for me? Or what if I'm wasting my time also? So, first of all, baseline, let's say all good starting part is that's a really good question, and it's always a good idea to share with your therapist what you're thinking, right? So you could always talk to your therapist about it and say, is this does this still feel like it's appropriate for me? Um, and a therapist that's experienced with OCD should be able to explain really why they think it's OCD and really what the treatment plan is and what you're practicing. So here at Stop OCD, our therapists are all experts in ERP and ACT and treating specifically OCD. Um, so that's kind of a baseline. But again, there's also a very like OCD type version of this question, right? So where the OCD can take the treatment itself and then turn that into a new kind of obsession. And then the compulsion could become researching the OCD and asking for reassurance, maybe comparing yourself to other people, to other people that you know with OCD, and people you see online, maybe reviewing your symptoms, checking over and over again. Um, these are all different types of compulsions that could be related to the treatment. So I think we can do the same thing and ask the same question, but from very different places. So I think a big thing is always to kind of ask yourself and say, am I trying to um, ask this question from a thoughtful kind of place to make sure that I'm doing the right treatment for me? Or is this kind of OCD taking over and trying to get me to kind of reach this absolute certainty? Um, And then if you feel like it's more the OC, then you can say, okay, say to yourself, you could say, I'm noticing this. This is my OCD. Maybe I still feel unsure. Um, and I can still continue and still take the next helpful step. So, again, that's kind of what I would say is always ask yourself, where is this coming from? And I think that would be a good starting place. So I see we have some questions. So let me read them out. 1 second. Okay, so the first question is, I'd like to know more about PRO. How is it diagnosed? And is it different from anxious overthinking and certainty seeking? Oops, sorry. So, okay, so that's, oops, answered. I put it moved it. Okay, so first of all, that's a kind of tricky question. So first of all, pure O is a term that a lot of people use. And why did I say it's tricky? Because it can be a little bit misleading. So first of all, let's talk about what it is. So pure O typically means this idea of pure obsessions, right? So this idea that the compulsions aren't there, but really that's what's kind of misleading. It's typically that the compulsions aren't overt, they're not obvious from the outside. So they're not things like hand washing or knocking or flipping the light switch a lot of times. Um, but typically, what's kind of misleading about it is that typically we actually can find a lot of compulsions that are done covertly or internally, mentally. So it could be things like mentally reviewing things or neutralizing a bad thought that I had with a good thought, or internally checking my feelings and monitoring my feelings all the time, or testing internally different things. Um, so really, I want to be very careful about this term pure O in general, and say that typically there are hidden compulsions, these mental compulsions that actually go with it. And we have actually a whole webinar all about that. So I really suggest that you uh, kind of take a look at that. And you asked how is it diagnosed? So first of all, it's not a separate diagnosis, right? I would still diagnose with OCD and look for the same OCD cycle, right? Of intrusive thoughts, of the intrusive thought, of the distress that's spikes, and then I would look for not an overt compulsion, but an internal something that's being done in an attempt to reach some sort of certainty or reduce the distress that was caused by this intrusive thought. So that's done mentally, which is really hard because I can't get into someone's head. But that's what happens when we talk through it. And then, so that's like the mental compulsion, and then there's short-lived distress, and then that's what actually reinforces the cycle, and then it happens again and again and again. Um, so again, in terms of being different from anxious overthinking and certainty seeking. So like I said, certainty seeking is definitely at the core of OCD. And really there is a giant overlap between anxious kind of overthinking or rumination, repetitive thinking, um, and certainty or reassurance seeking also. But in OCD, again, it's a little bit different in the sense that it's more kind of ritualized. It's as a response to this intrusive thought aimed at getting a certainty, or neutralizing a thought, preventing some sort of feared outcome. Um, so it is kind of slightly different. But basically, um, I hope I answered your question. Basically, takeaway is that pure O usually is a tricky term in of itself, and usually I don't like to talk about it in terms of not having compulsions. I think it's important to just drill down in terms of the mental compulsions where they're more invisible kind of. And really that's where a lot of the work is. Um, I'm going to look for another question. Okay. So somebody asked, do OCD symptoms improve for females post-teens slash 20s? I'm wondering if hormones regulate after that. So, I think in terms of hormones being involved in OCD, there definitely are influence, right? Um, right? Like we do know that symptoms can get worse, definitely around pregnancy, post menopause. Um, but I just want to be careful about putting it onto kind of later in life in terms of hormones kind of regulating, because we know that OCD really does spike kind of across a lifespan, right? And people are affected by a mixture of factors, right? It could be stressful life events, um, it could be hormones, it could be various different factors. And so really it could be a factor, but it really isn't the whole story. Um, I would just be really careful about putting it specifically on that. And I don't know any literature in the research that specifically um, puts it on that. I think in general, the main kind of important takeaway is that when we talk about treatment for OCD, we need to focus on kind of continuing this evidence-based treatment, which is exposure and response prevention. So really that different transitions in your life, whether it be getting a new job, getting married, having babies, or getting divorced, other stressful life events, hormones, things like that. So they don't kind of, it often happens that OCD peaks in those areas, and then having the kind of skills and tool set so that you don't have to have the OCD control your life kind of in those times. So basically, my answer is it's a variety of factors that contribute to OCD kind of cropping up throughout your lifetime, and that I don't know specific literature about um, hormones kind of regulating and then tapering off OCD in later in a woman's life. Um, if you have any follow-up questions, also please definitely write in. Okay. Okay, so next question. Okay, this is a long one. Okay. I have a patient who tries to ignore and wait out an intrusive thought. For example, 2 years ago, I killed a fly, therefore, I'm a bad person. Instead of going with a compulsion, for example, talking to his mother, he tries to wait it out. The obsession has been with him for more than 5 days, therefore, he refuses ERP. He fails to believe the thought will ever stop. Interesting. Okay. So I think initially it kind of looks like they're trying to do um response prevention, right? By themselves. They're trying to wait it out and not go and do the compulsion, right? That's what it sounds like. Um, but he's not actually doing ERP, right? Because he's not in ERP, we don't just wait it out, right? We don't try to wait until the thought goes away. So I think it's important to talk to your patient about really what the goal of ERP is, right? The goal of ERP isn't to prove that the thought is going to stop, right? Like I said at the beginning, intrusive thoughts happen all the time. We're human. I give this common example. I don't suffer from OCD, but it often happens. I'm driving in my car and all of a sudden, intrusive image of me getting into a horrible accident, me myself swerving the car. This is a classic example of an intrusive thought. And the thing is that I don't suffer from OCD. So I just think to myself, wow, that was scary. And I just think of, okay, that's part of the regular white kind of noise of my brain that my brain creates. And I don't assign importance and meaning to it. Right. So the goal of ERP, the goal of treating OCD isn't to prove that the thought is going to stop. Really, the goal is to learn that the thought can be there and that you can still live your life without doing the compulsion, right? So maybe in the case of your client, he's thinking that therefore he's a bad person. So maybe it's he wants to talk to his mom to confess or to review the event of killing a fly, or I don't know. Um, but really, in terms of ERP, we really need to practice being exposed to the thought or the any trigger and bringing up the distress of the moral conflict and maybe I'm the core fear of maybe I'm a bad person, and then really practicing staying with the idea of maybe the OCD is telling me that I'm bad, but I'm not going to solve this right now. I'm going to continue with my day and not doing the response prevention. Um, so I hope that helps. Let me know if you need any follow-up. Okay, so next question. Okay, great question is what is the course of action? So the evidence-based treatment that we use that is recommended for OCD and that we use here at Stop OCD is called ERP, or exposure and response prevention, which I just briefly talked about. And we actually have a whole webinars all about that. So if you want to go more into depth, I would definitely recommend that. But basically, in exposure and response prevention, what we do is we work with our clients on exposing them to, first of all, the number one thing that we're actually exposing them to is the distress, is the feeling, the disgust, the distress, the anxiety. And how do we do that? By exposing them to a trigger, right? So we want to very gradually, we work with our clients and do it very gradually. We don't want to bring on an overwhelming feeling. We typically work by building a hierarchy of different exposures. And we start with a mid-level range of distress. We rank them with our clients. And basically we work on exposing the client to the emotion that arises from the distressing emotion that arises from the trigger, from the intrusive thoughts. And then we work on, so that's the exposure part, the E of the ERP. And then the RP is response prevention. So we work on preventing the compulsive response to the that is aimed at reducing the distress that arises from the intrusive thought and the trigger. So basically, we don't we work on not doing any compulsion, whether that be hand washing, whether that be checking the stove, whether that be something mental like internally monitoring my feelings about whether or not I love my partner or not. And so that is the response prevention part of that. And then we work, like I said, very gradually through different levels of different exposures. So for example, let's use the example that I said about the internal monitoring. So that's something from, for example, relationship OCD or ROCD. So for example, you can have, if I have a client that has ROCD and they feel a lot of distress about whether or not they feel like the partner is the one for me, then, and their compulsions tend to be around internally monitoring their feelings when they're with their partner. Then, for example, we might do some ERP around, we could start with just looking at uh, photos of your partner and making sure that they're not internally monitoring as they're looking at photos and just talking it through. Again, it's very tricky when it's mental compulsion. You chose a really hard example. but but basically, yeah, so we work on exposing the client, having them feel a certain level of distress. Not, I go like this because we talk about the wave of the emotion, the emotion spikes, peaks, and we let it pass and we let it go down by itself without doing the compulsion by preventing the response. And there's a lot of work that has to be done around all of the exposures, a lot of cognitive work that we do. And at Stop OCD, we also combine this exposure and response prevention with acceptance and commitment therapy. So we do a lot of work also around values and committed actions, and do a lot of psychoeducation using a lot of metaphors. So this is a very long-winded answer into what is the course of action. But I hope that answered your question. And if you have more specific questions about Stop OCD, definitely check out our website. And if you have any questions, don't hesitate also to email our customer service also, which you can find on our website. Okay, so next question. You guys have very good questions. Okay, How is pedophilia themed obsessive compulsive disorder, POCD, treated? And can people who have this issue work involving children, or should they avoid such careers? Interesting. So, again, I think this is when we talk about different kind of subtypes of OCD, it all kind of goes back um, under the same cycle, right? We should treat them like we treat other, right? We have to assess them, like I just said, psychoeducation, treat with CBT, with ERP. We love working with ACT also. And I think specifically for pedophilia themed OCD, that's very, very important. The work, especially I think with ACT, because a lot of around shame and values and uncertainty. So I think um, what's really important here is this would go back to really the one of the key another key concept of OCD is this idea, we call it in clinical terms, that it's ego dystonic, which means that um, it doesn't align with a person's values. It feels kind of like opposite, these intrusive thoughts. Um, so for example, somebody could feel a new mom could have intrusive thoughts of throwing her baby off of a balcony, and she could be very, very afraid of that and say, what the heck? I would never want to do something like that. Um, and that really feels opposite to her values because she's a very careful and conscientious mother. Um, and so that's what we would say is being ego dystonic. So here we would want to really check first and to see if it's really something that's opposite to their values, or whether it is something that's really an active sexual interest, or if there is an intention behind it, um, and really try and differentiate there. Because typically people with this pedophile themed OCD is really, people are horrified often about their thoughts. And then they often become trapped in really the OCD loop of avoiding their feelings and avoiding children and reviewing all the time their interactions or testing their bodily reactions to things. Um, and so, again, with ERP, we would work on gradually reducing those types of compulsions, and also avoidance behavior. That's also really important. And then learning to really tolerate that level of uncertainty and that distress. In terms of what you asked about um, working with kids. So it doesn't automatically mean that someone is unsafe to be around uh, children, right? Or that they have to avoid um, all of the child-related careers, right? And that's could actually be avoidance behavior that could actually um, reinforce the OCD. But really, I would think that um, it should be discussed with a therapist that is an expert in OCD, especially if a person is trying to make a big career decision. Any big career decision is overwhelming and can be stressful. Um, so again, I think really we need to make sure, like I said, first, that it's kind of ego dystonic, the intrusive thoughts, that they are really something that are not aligned with a person's values, um, and really that we want to help the person live their life um, in accordance to their values and not um, live their life surrounded by having OCD dictate their their life and avoidance behaviors and choosing their career. Again, if you have any follow-up questions, don't hesitate. But yeah, you guys have really great questions. So next question. Um, so someone wrote, I have heard that OCD is a brain-related disorder, in brackets, neurodivergent, similar to autism and ADHD. So do people um, with OCD need to take medication? Are they holding themselves back without taking it? So that's a really, really great question. So OCD definitely is uh, kind of, like you said, brain related in the sense that there are real differences in the brains of people that have been diagnosed with OCD and people that are not diagnosed with OCD. We see differences in neural circuits. We see differences in learning patterns, in habit loops. Um, Really, it's important to say it's not something that's made up. It's not a weakness. Um, but we don't usually um, look at ADHD and autism the same way that we look at OCD, right? Usually, um, you wrote about neurodivergent. So autism and ADHD are typically considered kind of neurodevelopmental conditions. And OCD, it's a treatable mental health disorder, and it can develop over time, right? And you can have a biological vulnerability to it, like I said, with different brain kind of receptibility to it. Um, but it can develop over time. It's not you're born with it, that means you have OCD. So I think that's also an important distinction. Um, and in terms of taking medication, no, OCD, having OCD doesn't automatically mean that you need to take medication. It doesn't automatically mean that you're holding yourself back if you're not taking it. However, everything is two-sided with in psychology. There are people that strongly benefit from taking medication for their OCD. I know certain therapists that won't see certain clients until they start taking um, medication until they so that they can actually do the exposure and response prevention work. Um, and like I said, so the first line, like evidence-based recommended treatment for OCD is exposure and response prevention. And the recommended medication for OCD are actually SSRIs or selective serotonin reuptake inhibitors. And again, it depends on the kind of severity of it, the preference, maybe if there's comorbidities in the background. Um, so typically, I don't want to say typically, actually, it very much depends on the case. Like I said, it depends on the level. If it's more severe, then we would start with medication as we're starting cognitive therapy CBT as well. Um, but yes, so basically it's not um mandatory, but it really, in some cases, can really be an important step of recovery and really go in conjunction very well with exposure and response prevention. So I would definitely consult with um uh your psychologist or eventually with a psychiatrist and to see if that's a good fit. Okay, are there more questions from the participants? I just want to check. You guys have really great questions. If not, I can go back to um my um questions that I have. Okay. Sure. I'll go back to questions that oh, this is a good question that one of the therapists wanted me to talk about. So the question is, why do I have to talk about myself, my past, my family, or my values if the problem's OCD? So I think that's a great question, because a lot of people come to therapy for OCD and it's specifically CBT or cognitive behavioral therapy, and they think, I don't want to talk about my childhood. I just want tools. I just want to stop the compulsions. I just want to feel like I have my life back. Um, so you'll get that. You'll get tools. And it treatment for OCD shouldn't be this endless cycle that we're going through over and over and over, analyzing the past, because that could actually feed into OCD. Um, on that being said, OCD doesn't happen in a vacuum, right? It happens within a person's life, and sometimes we need to understand more about our client, more about the person, in order to understand what is happening with the OCD, right? Because really your life's context can really tell us what OCD is kind of hooking itself kind of into. And a really important thing here is, I don't think I've mentioned this yet, is the idea that um, underneath a lot of underneath intrusive thoughts and underneath different people's OCD is something we call a core fear. And a core fear is when you get kind of to the end of, if you go through like a downward arrow, we say, and then what, and then what, and then what. So if you have an intrusive thought, or from an example that you guys gave, so somebody said an intrusive thought of, oh my gosh, I killed a fly, and then the core fear, there's, I'm a bad person. Um, maybe the core, like, we'd have to ask the client even more, maybe do a few more steps and see if the I'm a bad person means that I'll end up alone, or maybe it is just that's where it ends, that I'm a bad person and that's my identity. Um, and it's really important for me to say that two people can both have this kind of harm OCD, that they're fearing of harming a fly or harming, like I said, with the new mom throwing a baby over, and they could have different core fears. So one person might have the core fear of I could be dangerous, and the other person, it could be I'm a bad person, I'm morally bad. And so going back to this idea of why do we need to understand about the person and the history and the childhood, is that when we're building our exposure plan, it can look similar on the surface when we're getting exposed to different, when we're working with different triggers to expose to the same emotion that comes up. Um, but we need to make sure that the emotional meaning has to be connected to the core fear. So the emotional meaning could be different. Um, and so basically, I think it's really important to understand that when we're doing all of this kind of research, history taking research, and work with a person's life context, it's to understand the context in which your specific OCD um, is growing and taking place, and then from that we can build your own specific exposure plan. Hope that makes sense. I'm gonna check the Q&A again. Nothing. Again, please don't hesitate. Okay, another one that another question that I was suggested is about how can family members support someone with OCD without giving reassurance or accommodating rituals. And this is something that I really like to talk about. So I said accommodating rituals, and this is a topic that I personally really like. It's called accommodation, and it's the idea that basically family members or loved ones often kind of get pulled into a person's OCD cycle, and it's really done out of love, right? They're trying to help the person. You really want to help your loved ones suffer less. Um, but that's really, really tricky with OCD because it often ropes kind of the family into being part of a compulsion. So it could be repeatedly providing reassurance. Um, like with harm OCD, are asking, are you sure I didn't harm anyone? Are you sure um, the baby's okay? Something like that. Or with contamination OCD, are you sure I'm not contaminated? Are you sure I didn't touch the garbage? Um, but it can also look like changing a family's routine. I'm thinking about clients that make everybody put on shoe covers all the time, that make their kids come home right away from school and get right away into the shower. And there's no such thing as bringing outside clothes or things into the house. And then it takes over the life. Um, and what's important here is that this idea of reassurance and accommodation, it's like compulsions, right? It works in the short term. The person in the short term feels slightly calmer, can breathe a little bit easier. Um, but really, what happens here is that the OCD learns and it strengthens the cycle. It's really, like I said, with the OCD cycle, um, and it strengthens the idea that the brain learns I needed that reassurance to kind of survive that distress and that the distress caused by my intrusive thought. And then what happens is that it comes back stronger and stronger and stronger. Sorry. So basically, what if we go back to the question of what can a family do or a loved one do to support is essentially the idea of um, being kind of warm and supportive, but having boundaries. So you're gonna say something like, "I know this is really hard right now, but I'm not gonna answer the OCD's question." Um, Something like that. Um, And it's important for families and for loved ones to have information and to receive psychoeducation about this also. We have on our website, I think it's a blog post. I uploaded it as that. But I helped write an article. If you search accommodation on our Stop OCD website, we have actually a handout that you can provide, download, and send to family members or loved ones to teach them about OCDs, just very basics, and about accommodation and how to really you can help um, really just support the person and not support the OCD. We have time for a few more questions. Nobody wants to write anything in? Any follow-up questions? Okay, I'll go back to my questions from that I prepared. So, um, one of the questions is, um, why does OCD target the things that I care about the most? Um, and this is something that is often really kind of validating for people to hear because um, it's true. OCD often targets the things that you care about most. So, because like I said, it's it came up when we talked about the pedophilic obsessive compulsive disorder. That the idea that things are ego dystonic, and um, so really it's if somebody cares about um, things like being kind, then OCD may send harm thoughts. Um, if someone cares about their really deeply about their relationship or have a core fear, I guess, of being alone, then maybe it could OCD would attack kind of the certainty of being um, uh, of their relationship. And really, it doesn't mean that the intrusive thoughts are true. It often actually means the opposite. And really, that's where OCD kind of latches on, is where it's the most important and your stakes feel kind of the highest. Um, and so really what we do in therapy, and especially that's why I love work with acceptance and commitment therapy, is that we work on values. We work on living your life according to a values based way, and that we don't obey the OCD, and basically we um, try to live your value directly. Um, I hope that answers it. Okay, so I see we have two more questions. I think we'll go back to these, and if you have any more, I think we'll stop after these two. And then if you have any more questions, you can send me an email. I can write it into the chat at the end. So, okay, the next question, I will read it now, is how about OCD in religion, in brackets specifically Christianity, scrupulosity OCD, what approaches can be taken? So let's just talk about this in general. This is a great question. First of all, we actually had a whole webinar all about scrupulosity OCD with an expert in the field, and I definitely suggest you check that one out. But basically, the idea in scrupulosity OCD is that the OCD attaches itself to faith, morality. It can be involved with intrusive thoughts around sin, confessing, um, checking whether or not you're good enough in God's eyes. And really, what's important is to really separate faith from OCD rules, right? So in treatment, we don't want to make somebody less religious or challenge their religious beliefs. It's about helping the person practice their faith without compulsions, without endless certainty seeking. So, like I said before, if maybe it's repeated, specifically in Christianity, maybe it has to do with repeated confession. Um, then in ERP, in exposure response prevention, we would gradually work on facing this feared uncertainty while resisting the repeated confession, the ritual. Or it could be something like praying once and not repeating it if it's about repeatedly praying. Um, or allowing for an intrusive and blasphemous thought to happen, um, and to not try and neutralize it. Like, remember, I talked about the covert compulsions. Um, and so I think that's the approach that we would typically take, especially in exposure and response prevention. And in terms of acceptance and commitment therapy, we would talk really again about values here and say, what would faith kind of look like if the OCD wasn't controlling my faith? Um, so I think those are kind of the approaches that I would take with that. I hope that answers your question. Um, yeah, I think really just the main takeaway is that we don't want the we don't want the treatment to ask the person to abandon their faith. We really want um to really get to get the person to stop letting OCD use kind of their faith as a weapon against them, right? Like I just said, it gets typically into the areas that are the most important to us and where the stakes feel the highest. And then it kind of latches and hooks onto those. So we don't want to let the OCD kind of be a weapon there. Okay, last question. I've been trying to help my certainty, finding thought, I mean, trying to help my certainty, finding thoughts that triggers by pushing back and just kind of making my mind go somewhere else. So, for example, a situation triggers me, then I get a question in my mind, and my mind almost pushes it all down by saying these are not going to help me and they're not useful. But I wonder, is that repression or avoidance that is ultimately unhelpful? Okay, so I just want to make sure I understand the question correctly. So basically, is pushing the thought away or kind of redirecting my mind, is it helpful or is it avoidance? So this is a really great question. I'm happy we're kind of ending on that. Um, because the difference here is can be really subtle, right? So again, like I said, we can do things often different the same thing, but it can be from different places. So often in OCD, it's usually the issue isn't about redirecting your attention because redirecting your attention can actually be really helpful. The issue is whether from what place are you doing it? Are you doing it with depending on the goal? Is the goal of pushing, kind of redirecting your attention, is it to push the thought away so that you don't have to feel the distress from the uncertainty? Um, or is it that I'm gently trying to say, this isn't important right now, and I want to focus on what's important to me, returning, kind of getting out of my head and getting back into my life? Or is it that I'm trying to force it out of my mind? Um, so if you're saying to yourself, okay, when you ask yourself that question, you're saying, okay, yeah, no, the thought, this stressful thought, it's not helping me right now. I'm not going to solve it right now. I just want to return to whatever I was doing. I want to return to feeding my baby. I want to return to chopping a salad. I want to return to the conversation that I was having. That can be really helpful, right? That can be a helpful um, shift of attention. But if you're doing this with the goal of saying, I need to get this thought out of my head. I can't feel the distress that it's happening. I need to distract myself. Then it sounds more like avoidance or suppression. Um, and really, our goal isn't to shove thoughts down, right? Because they just crop up again. The goal is to learn that I can allow these thoughts to be there and I don't have to give them my full attention. Okay. Um, so really, I think the bottom line kind of here is that redirecting attention is very helpful when it means that you're trying to return back to life and get out of your head and live in the present. But it really becomes avoidance when we're attempting to kind of make a thought, an intrusive thought, disappear. So I think that's the fine line. So thank you everyone for joining. Um, I hope you guys enjoyed. If you have any more questions, you can send us an email. It's on our website, stopocd.com. Thank you. The session was helpful and great. I'm happy you guys engaged so much. Thank you for all your wonderful questions, and we'll send out the recording shortly. Bye, everyone. Have a nice day.